All right. So good evening, everyone. First of all, let me thank AIOS and Dr. Somshila for making me a part of this wonderful session of uveitis. And like Dr. Sudarshan said, I will be dealing with some other issues in uveitis, mainly masquerades. So uveitic masquerade syndromes basically are a group of disorders that present as ocular inflammation, but are in fact non-inflammatory diseases. Or they may be the case where the inflammation is secondary to another initial disorder, which may be either intraocular cells, and opacities are basically of non-inflammatory origin. Now, these can be either pigments, blood, or malignant cells in some of the cases. So let me show you a few cases. So this slide is courtesy one of my colleagues, Dr. Anamika Patel. And what you see over here is a brown tinged hypopyon in one of the eyes, and other eye which has got an atypical hypopyon over here. Now, whenever you see a patient who has got a brown colored hypopyon, please think of some other causes. So why does the brown color appear in the first place? Necrotic iris and dispensed melanin granules are the underlying cause behind these brown colored hypopyons, and you can see them in cases of uveal melanomas, sometimes in TB or listeria. Now let me show you a few cases. This was a 63-year-old gentleman who came to us, known patient of diabetes. And after 1 week, initially he presented with a hypopyon uveitis, but within 1 week he came back with this intense blood-stained hypopyon and a thick coagulum in the AC. Now we went ahead and did a AC tap for this patient. And when we did a AC tap, what we found to our surprise was these multiple myeloblasts, band cells, metamyelocytes, and promyelocytes. So a recalcitrant or blood-stained hypopyon should alert us to the presence of a masquerade or an underlying blood dyscrasia. And a peripheral smear can be extremely valuable in these cases. Another patient, known case of leukemia. Now, presence of hypopyon in a case of leukemia should alert us to the possibility of number one, either a relapse or a lymphoid blast crisis. It can also indicate the presence of a CNS spread and a leptomeningeal involvement. So if you see a patient of leukemia presenting to your clinic with a hypopyon, remember your role becomes extremely important, because now you will be the one who will be able to probably diagnose an underlying blast crisis or a leptomeningeal involvement. So let me show you one more case. This was a lady who presented to our clinics with a vision of PL plus PR inaccurate in both her eyes. A slit lamp examination showed a dense fibrinous reaction with no view of pupil and iris, intensive DM fold and circumciliary congestion. The AC was shallow and there was a stromal edema. This patient actually had been initially thought of as a bilateral angle closure glaucoma, and somebody had advised them to undergo a YAC-PI locally. However, when we went back and took a history, and that is where history taking becomes such an important tool in uveitis. Not only uveitis, for that matter, any branch of ophthalmology, or for that matter, medicine, we cannot undermine the value of a good history taking. So when we took a history, we came to know that this patient was taking topiramate since the last 15 days. A B scan showed these peripheral choroidal detachments in both the eyes. And then, like I said, this patient was taking topiramate, which had been started 15 days earlier. There was no other significant family history or any history of any allergic disorder. So this was a patient who had drug-induced anterior uveitis with choroidal effusion because of topiramate. And all we needed to do over here was stop topiramate, start this patient on topical steroids and systemic steroids. And on just third day, you can see that most of the reaction is regressed, the cornea is clear, the membranes have regressed, corneal edema has regressed, and the CDs have also started getting regressed over a period of time. So at 1 week, the visual acuity has improved to 20/50 in the right eye and 23/20 in the left eye. And this, like I said, was a case of topiramate-induced anterior uveitis. This was another case. Again, topiramate-induced uveitis, patient came with bilateral hypopyon. There was an attempt of a surgical PI done somewhere else, which ultimately resulted in the patient developing an intumescent cataract subsequently. But again, this was also a patient who had been started on topiramate and had developed this reaction. So whenever you see a patient with sudden onset of bilateral hypopyon uveitis with a shallow angle, with choroidal detachments, think of drug-induced uveitis as another one of your causes. So apart from topiramate, chlorthalidone, hydrochlorothiazide, trimethoprim, sulfamethoxazole, and even acetazolamide has been shown to lead to this occurrence. So this is a case which shows the disastrous consequences of not recognizing this entity. This was a patient, again, who had presented somewhere else before she came to us, and somebody had tried to attempt a bilateral phaco to remove those bilateral intumescent cataracts, whereas what they did not realize was that this was a patient who had started taking chlorthalidone a week before the onset of symptoms. and she developed these intense membranes because of this misguided attempt at surgery, whereas all it needed was to stop chlorthalidone. We went ahead, did a membranectomy, removed those membranes and put oil inside the eye to take care of the hypotony. And this is how the eye was subsequently. But in a nutshell, please remember, when you see such an atypical presentation, keep in mind an index of suspicion for a drug-induced uveitis also. Another case, bilateral hypopyon uveitis for a patient on treatment for tuberculosis. Think of rifabutin. So anterior uveitis occurs as a dose-dependent effect of rifabutin over dosages of more than 300 milligram. This condition may be asymmetrical, and sometimes the hypopyon resolves just on the cessation of rifabutin. So there's a huge plethora of drugs which can cause anterior uveitis, including rifabutin, bisphosphonates, sulfonamides. But the point which I want you to remember is that when you see such atypical presentations, please keep in mind the fact that you might not be actually dealing with a primary uveitis etiology, but something else which may be the cause of these problems. So point to remember: atypical hypopyons, recalcitrant blood-stained hypopyon, think of a masquerade or a blood dyscrasia. Bilateral hypopyon plus choroidal detachments, drugs like topiramate. Hypopyons in a patient on treatment with tuberculosis, think of rifabutin. And hypopyons in leukemic patients, impending blast crisis or a CNS spread. So whenever things are not fitting in the way they are, it's always important to go back, take a proper history, do a more meticulous examination. Peripheral smears can be extremely valuable in arriving at a diagnosis, which will help us in basically not erring towards something wrong and trying to treat our patients better. Thank you.